Hello everyone. We have already seen the first X-ray for this case, an external resorption going parallel to the nerve until half the root of this 1.5 tooth. From the cone beam we can get some information. In a sagittal section we see that there seems to be some contact with the periodontium in the posterior part. In the frontal section we can identify a perforation towards the palate at the middle third of the root, and in the transaxial section we can see well the two perforations we should expect when we get 3-4 mm under the bone. Once we locate the defect, all the practical clinical approach becomes easy because in the end it all starts by an ordinary devitalization. Let's perform an access cavity as for an ordinary devitalization. Let's identify the two root canals, then you know how I typically use M2s. Let's carry out the root canal treatment. The apex locator works regularly. It generally doesn't go crazy when detecting granulation tissue. Once molded the root canals, after excluding that the bleeding we will later observe in the external resorption is of nervous nature, we can then start widening the access cavity towards the defect. Since we know it's located around the palate, we need more visibility in that area, so we slightly modify the access cavity. As you can see in this video, we use a StartX 1 to widen the opening slightly. You can also do it with a bar. You do this to have a better visibility. From here, getting to that area is absolutely not complicated, nor far, nor unreachable with a microscope. The first phases of this kind of intervention are always a little hectic, because even if you were expecting to find some bleeding tissue, when you get there it's a big mess. Everything starts bleeding, you feel frustrated because you think you are dealing with an impossible to recuperate tooth, you scratch here, rub there, even what you thought could never bleed starts bleeding instead. Overall, the whole experience is somewhat traumatizing since you witness bleeding in a part of tooth which isn't supposed to bleed at all. Here you can see that I'm putting a little tip for composite to clean well into the defect, otherwise you'd have to roughly suction everything out and it would really get on your nerves. Once you have cleaned all the defect with some microcurette, you realize that there are some undercuts which prevent you from seeing the defect well. Therefore, we can widen it with some turbine bars. With the microscope, you are fully in control of what you are doing. Then we peel on our way out as if we were making an opening access for an incisor to take out the undercut below the cingulum. And this can be done with diamond ball bars on a turbine, or, as we can see now, even with a rose bar for contrangle, which work a little more slowly and can help remove the granulation tissue, understanding where the dental tissue starts regaining its consistency. This said, all external root resorptions are different from each other, because the oldest one's texture is really similar to a bone, and those are a little more complex to deal with, since it's actually quite hard to distinguish where the granulation tissue ends. In this case it's easy instead, it's really soft. Here we can see the two perforations. Look how well you can see with the microscope. That's the perforation on the palate we expected, but there's no granulation tissue anymore, and you can see how clean and shiny the tissue is all around. And this is the distal perforation where it touched the periodontium. When we get to a situation like this, we are ready to fill the defect. I think that actually several methods can be used. For instance, in some cases I've used biodentin, as I mentioned in my post, but here I use the classic MTA. To prevent MTA from dripping into the root canal, I'm placing a paper cone in the main root canal, which was just one in this case, and I'm creating an ischemia with 36 volumes oxygenated water into the defect, as you can see right now, to prevent it from bleeding when I start placing the MTA. However, both MTA and biodentin are materials that can tolerate some bleeding and harden in wet environment. Then I start placing some MTA and I prefer to adapt it with some little brushes. Honestly, I never manage to work well with the MTA gun, which always gets stuck, so I put the MTA at the edge of the cavity and I push it down with a brush. Do this several times until you feel all the cavity. Then, as we know, the MTA needs to be in wet environment for 24 hours to harden at its best. So at the end of this procedure, we will cut and remove the paper cone that we had put as soon as the MTA started becoming solid. We made it well compact, so take a paper cone, moisten it with physiological saline, clip it and put it inside the cavity, then put the usual wet cotton pellet, put some cavity paste on it and check on the patient 24 hours later, because we know that is the best moment to get the best physical mechanical characteristics of MTA. I've been using biodentin lately. It presents some benefits because in 12 minutes it hardens and it allows you to finish the root canal treatment within the same session, and I like this a lot. In some cases, I feel the root canal first, then I insert biodentin and I feel up to the occlusal level, since biodentin can stay up to 6 months in a state of occlusion, thus allowing us to monitor the tooth over the weeks following the intervention. Anyways, the patients on which I make these interventions are always asymptomatic after this procedure. It's nothing traumatic or worrying. Here you can see that the MTA is compact. At this stage I remove the paper cone, as I said before, and that's the end of the first session. During the second session we'll finish the root canal treatment by inserting a thermophil in the canal you can see here. By treating a tooth like this, you can see that the approach is very conservative, and I don't think that such a treatment can only last a short time, as Heathersay stated in his papers. That's a tooth I choose to rehabilitate with a first-class feeling, because the patient was intercepted during an invisible orthodontic treatment and I didn't want to change the tooth shape. Since the result of the filling was good, as you can see in my blog, and it looked fine, I left it, given the tooth was perfectly solid in its coronal part. The only hope, or rather the only doubt, is whether the MTA and the hole in the root will last from a mechanical point of view, but I'm absolutely positive it will. So that's the result, and see you next time.